Thank you. Thanks for coming today. This is actually great attendance. Thank you all. Thank you all very much. First, has everybody had an opportunity to review the minutes for our March 7th meeting? And is there a motion for approval? Dr. Vogel, thank you. Second? Dr. Ashkow, excellent. Thank you. All in favor? Excellent. Thank you very much. I'd like to move quickly into some correspondence. The first, we have a letter from the Department of Health, Dr. Nirav Shah, informing us that Columbia Memorial is now a designated stroke center. It will be added to the list as such. I have a letter from Mike Tarbox to Tim that I'd like for us just to discuss briefly now while we're on the subject, which is asking about when to get signal numbers and when not to get signal numbers. We've had this discussion in the past, and these are different. These were signal numbers for an EKG when the patient is BLS, and signal number for EKG only when it's an ALS transport, which is an interesting question. I'll open that to the floor first. Don?
Mike, can you kind of repeat that once again?
Yeah, basically, Mike Tarbox, who's the ALS coordinator down at Greenport, is interested in knowing whether or not his provider should get signal numbers for EKGs when their patient is ultimately transported BLS, and whether or not you should get a signal number for an EKG only if it's an ALS transport.
Is this a STEMI transported BLS?
I mean, he's just getting an EKG and then he wants a signal for it.
I'm not exactly sure what the idea with the signal number for EKG turf to BLS transport is. Our standard is an ALS call gets a signal number. This question probably has more to do with a billing scenario of ALS assessment and whether or not if there's an ALS assessment of a patient that ends up going BLS, they should get a signal number.
If you're concerned enough to do a 12 lead, should you be BLSing them? I've actually had patients arrive in the ER that BLS reports they had a 12 lead in the field and no 12 lead came with them.
We've dealt with that more than once.
I think that thought process is really important. Just because you have one EKG certainly doesn't mean they're fine.
Right, we could turn around at the door if that worked. EKG, you're fine, Bob.
But in any ALS modality, I thought was under the requirement to get a remote number, not whether you actually brought them in and to perform an ALS modality, hooking up to monitor is an ALS modality, so you can call it for a number. That was what my understanding was.
That sounds like a reasonable line in the sand.
Sounds good.
And I don't think that requires any votes. That's just a question of our
What it was.
assessment of what the plan was, and I think that says it pretty well, Jeff. Okay. And Tim, if staff could take care of answering Mike. Thank you. We had some correspondence which led to a letter that went out from this office to Johnsonville Volunteer Ambulance, where we had been told that there were some response issues. We'll deal with that under new business and then review the response under there. Academic committee, Dr. Doyle.
Okay, a few things. Part of it, I guess, is going to be addressed later, looking at what you have planned here. But drug shortages were brought up yet once again. It looks like fentanyl is less of an issue, but now etomidate is nowhere to be found. And Versed is going to be a problem. Although Mike did bring up one pharmacy does have different dosing concentration that is available. Mac sulfate, I guess, is going away for a while too. So this is not a non-ending problem that doesn't seem to be going anywhere, unfortunately. We'll just keep working with it. Let's see, regional training courses, we do have a list of regional training courses, if anybody's interested, a bunch of EMT courses are out there, a first responder course as well. But those are available either here or on the Remac website. The next thing that became a bit of an issue is precepting and cost of precepting. Now it's becoming a little bit of an issue with agencies paying their preceptors to train the students when they do their internship, which isn't so much a problem if the students are actually on their agency, but it is a problem when they have no affiliation. And there's going to be a problem with how the colleges are going to be able to pay for this, and who's going to pay for it. Ultimately, it's going to be the students. Obviously, they're going to pay for it. I suspect it's something that's not going to go away. As much as we probably would like to, it's probably just got a life of its own now, and it's going to be a problem. But we'll keep you up on that. The other is membership to the academic committee. For the first time in 20 years I've been on the committee, we actually have people who applied and voted in. So there now is actually a membership list, rather than just sort of whoever shows up that day. And that's basically it.
Excellent. Thank you very much. Any questions for Dr. Doina? Gotcha. Remsco. Rich, you want to talk about happenings at the Remsco?
I can't think of a thing, Doc. I honestly can't think of much of anything. Jeff?
Wasn't there?
Nope.
You weren't
Nope.
at the Remsco?
You
Okay.
were right, they had it available.
What?
You were right, Cardinal had it available.
It happens sometimes.
And I just ordered 6.
It's a
Excellent.
20-minute meeting.
We had a 20-minute meeting.
It was brief.
It was very brief.
Not a record, though.
I'm sorry.
It was not a record.
It was not a record, no. We had a 20-minute Remsco meeting. There is a certificate of need application in our region. Want to bring that up. There's a public hearing on the matter this coming Monday evening at Tamarack High School, if you're interested in
No,
attending.
not at Tamarack High School. Where is it?
It's the Brunswick School District, but it is Tamarack.
Tamarack High.
Okay, just not listed that way on the notice. Okay.
The correct name is listed, but everybody calls it Tamarack. The address is correct.
Cambridge Valley Rescue Squad, which is an agency from the Mountain Lakes region, located in Washington County specifically, has applied to provide service in the town of Hoosick. And I think that's really all the big news from our Remsco.
I think so. The other thing mentioned briefly at the Remsco as well is the changes to Article 30 that were in the original governor's budget have been removed from the budget that was passed.
Correct. Yes, correct. For this year, I feel, and I think Steve, our lobbyist, thinks it will likely come back next year.
So, any comment on that, Mr. Farrow?
Nope.
I didn't think. All right, CMAC no meeting, SEMSCO no meeting, although both do still exist.
Yes.
The HOC, you want to talk about what ADLS and BDLS is?
Oh, basic, actually, Art could expound maybe, but Albany Med, once again, is hosting basic disaster life support, following that, advanced disaster life support. And help me out, Art, I don't think they're at the Med, they're off-site, aren't they?
Yeah, one's at SUNY Public Health and the other will be at Hudson Valley. Registration is filling up quickly.
Excellent. Those are good courses put on by UT Southwestern, right? Agency upgrades, BLS albuterol, epi, and glucometers, none. ALS upgrades, none. BLS FR, there is a significant list of folks that are assuring that their documentation is indeed correct. Nothing to do for us. EPCRs, we have 3 groups of providers that are now on EMS charts, including NISC unit FD number 2. Town of Corinth, refresh me for a second. Town of Corinth is the same as Jessup's Landing, right? Okay, thank you.
All 3 of them.
What?
All 3 agencies under Jessup's Landing.
Okay. Gotcha. And Boston Lake EMS is doing EMS charts. Excellent. Public access DFib. We've got some updates and some original applications. Quick question, Dean, you had said that we had gotten some paperwork returned to us. Is that all taken care of?
Yes.
Okay. And that looks like it may have been an administrative error on the part of the department, or?
Most likely, yes.
Okay, gotcha, thank you. New business first. Standardization of the regional restocking form. The regional restocking form has been completed. It's been approved at the regional council. Has been written by the nurses committee, and all of the hospitals should be on board with it. Of note, as we had discussed in the past, there are a few drugs that will not be restocked, among them ketorolac and oral ondansetron, as well as any controlled substances and anything else? And Cardizem, because agencies were making decisions on which Cardizem they were going to carry based on their own internal business plans. But that should all be in place now. Johnsonville ambulance, we had gotten some questions as to whether or not they were staffing adequately. We asked them to send response data for the last 6 months, and we received a letter from O'Connell and Aronowitz today by fax. Dear Mr. Moradley, this office has been retained by Johnsonville Volunteer Ambulance. Your recent correspondence to Johnsonville has been referred to me for a response. As you know, Johnsonville is an all-volunteer ambulance agency providing basic life support to areas within the town of Pittstown and the town of Schaghticoke, Rensselaer County. Johnson Volunteer Ambulance has been in existence since 1963. In response to your recent correspondence, please be advised that Johnsonville Volunteer Ambulance Squad has a rotating schedule of 2-person crews, including a driver and a certified emergency medical technician, during months of September and October 2011. A search for such schedules is being conducted, and they will be promptly provided if located. For the period encompassing November 1st, 2011 through February 29th, 2012, Johnsonville Volunteer Ambulance Service did not retain any records which would reflect specific scheduling. Rather, if Johnsonville was dispatched to a call, any available personnel proceeded to the station in order to respond. As a New York State certified provider, all calls in which JVAS responds include at a minimum a driver and an EMT. During early November 2011, Johnsonville Volunteer Ambulance did encounter some difficulty in being able to respond to calls for a period of approximately 17 days. This occurred as a result. Excuse me.
Annie, can you speak?
You're very bad place to have that.
This occurred as a result of a couple of unfortunate events, which included one of its EMT members having her certification lapse and the termination of another EMT member. During this period of time, thank you. Thank you, sir. During this period of time, neighboring EMS agencies were advised, as was the Rensselaer County Department of Public Safety. In order to address this situation, efforts were also made to secure the assistance of 3 EMTs from neighboring agencies. These persons were voted in as members of the JVAS on an emergent basis, and while such personnel did assist on some calls, their commitment was not to a level that JVS had hoped. With respect to the specific time period you have requested, JVAS was dispatched to a total of 69 times and responded to 38 calls. JVAS is working diligently to provide emergency medical services within its territory following this unfortunate but brief period. In this regard, the EMT member who had their certification lapse was recertified in January 2012, and she has been actively responding to calls since that time. Another member of the agency is currently enrolled in the EMT program, will be taking the certification exam in May 2012. In addition, Johnsonville Volunteer Ambulance is exploring other ideas in an effort to increase its membership to continue to provide basic life support service to the community as it has done for almost 50 years. If you have any further questions, please do not hesitate to contact me. Very truly yours, Tom DeNovo.
You know they spent more getting that letter written than they did on staffing for that period of time.
Volunteer agency.
I am fascinated when a request from this agency from the program agency that is responsible for oversight of EMS in the area is instead retains counsel before, an agency retains counsel before sending a letter which contains exactly the information that we asked for. I think that has more to do with the relationship that this agency has with its neighbors, and the fact that the complaint that led to this request came from one of its neighbors. So be it, they made the decision, they hired counsel, they have answered the questions that we've asked. It raises some very interesting questions, not the letter, but the concerns in terms of what we do from a regional perspective for basic life support agencies that are not responding regularly, responding to about 50% of their calls. I'm sure someone would call me on my math. 38 is slightly more than 50% of 69.
That's a higher response rate than what I was hearing. I was hearing more like 5 out of 65 were responded to.
Yeah, it's actually some different numbers than I was hearing as well. And the interesting thing is that the numbers that I was hearing were supposed to be sitting in hard copy in front of me and are not, which is something else that we will be addressing. So I think this answers our question, demonstrates that the squad is indeed recognizing that they have a responsibility to their community of actually getting out the door, and sounds like they're working on that. Now, Evan, in terms of their discussions with the county when they were in their period of crisis back in November, did they have somebody else responding instead of them?
Yes, they did.
Okay,
They
good.
put their neighboring squad on all calls, first dispatch.
Good.
We have a 369 default,
Mhm.
and they were unable to commit to having that crew, so they put Hoosick Valley on simultaneous dispatch. And as an aside, and I certainly have nothing more than good speculation, but the town of Scottico, which Hoosick Valley served as well, recently withdrew any funding for Johnsonville, and I just have to wonder what the motive behind all this is anyways. Because coincidentally, where did that money get reassigned to? Perhaps another agency that serves Scottico. Again, speculation, I haven't seen the budget transfers, but you just have to wonder the motivation behind some of these things.
Mhm.
So that's my concern. There was a very productive meeting on Friday, and it was basically, you guys got to get this fixed. And they are discussing other methods, including doing some reimbursement for crew members that were not motivated before. So it's trying to be nice. But in any event, it is a problem up there. It's a very small community, small pool to draw from, and they are focused on fixing the problem.
Gotcha. Who's going to be guiding them? Any idea? Because for those of you that don't know, this is actually Mr. Eisenhandler's last meeting as a representative from Rensselaer County, as he is
Till the end of
retiring
the
as
month,
EMS
I'm doing
coordinator.
everything I can. I did offer my services after I'm out of the position, not in an official capacity. So I don't know. I'm going to assume that they're going to continue to call, and I will hopefully transition that to my successor at some point.
So you're retiring from government to become a consultant?
We do it.
Unpaid consultant. That's even better. Spiritual thing, Mike.
Thank you, Evan. Any questions for Evan?
Other things. I've had some calls where other opportunities. One door closes, the other one opens. I'm not going to disappear.
Good luck.
Thank you.
All right, any other questions about Johnsonville? All right. Closed, thank you. Drug shortage update. I gave a brief report of this to the academic committee, where I was asked what's going on with the drug shortage, and I said it exists and it's awful. Mike, do you have anything beyond that for us?
I'll second that.
Okay.
No, I mean, I think it's rampant. It's unacceptable. Will it improve anytime shortly? I don't think so. It leads to medication errors because we're dealing with unfamiliar concentrations, medications that we haven't used for a long time. And I think that low-cost generic injectable medications are going to be a thing of the past. I think that what will drive it is if they're able to make money off the medications, and the prices will go up significantly. But
I think had a problem, actually, we mentioned that IV Zofran seems to be an issue now too. Seems to be disappearing. It's not in the hospital, but pre-hospital.
We have a limited stock in the hospital for the IV Zofran now.
Switch over to the oral tablets for the month.
Which becomes an interesting one, because if you give the IV Zofran and then you give an injectable opiate, you have now hit an ALS2 bill. But if you give oral Zofran and then you give an opioid, you're at ALS1.
just combined with Toradol. Just combined with Toradol.
There you go.
That's a choice too.
That shortage also.
Yeah, actually, there are a lot of agencies out there that have never actually stocked ketorolac at all because it's not available. And that's not one that we will ever consider a crisis, worthy of work. So.
So what's the current conventional wisdom as to why the shortages are out there? It's evolving, right? From the manufacturers, just not.
Manufacturing
It's
issues.
regulations, right?
It's regulations, right. It's the FDA, looking at things that it hadn't looked at before, and it's ultimately money. And it's the number of generic manufacturers for generic injectables has shrunk over time, and now there's just a few big manufacturers, so it's caused.
What's really strange about this whole thing, the catch-22, is the payers, the insurance companies, are so entrenched, at least in this region, against allowing prescription of any non-generic. You try to write for a label version of, whatever, and you're going to get calls from pharmacists saying, you got to write for a generic, it's not formulary, or of course we're not getting the kickback to push the label.
Right.
So it's kind of like if the payers are saying, we're going to encourage use of generics, but that's going to discourage innovation and development because everything that's innovated and developed is labeled until 18 years have elapsed or whatever it is generic. But you're saying at the other end, for the injectables, they're not encouraging development or continuation of manufacturing of generics.
Too bad there can't be regulation or some kind of requirement for every new label drug that a particular manufacturer wants to have approved. It must maintain manufacturing 5 generic drugs. How about that? Let's make a proposal.
Yeah.
And that endorses the
Is there any
policy.
government
Is there nothing that
agency looking into it?
I mean, I think the FDA's looked at, I think ultimately what it may require is, some type of stockpile to exist. Or, these are critical medications.
You don't know that they're short until they're short.
Right. You can't draw it down until it's drawn down.
Right.
Well, in some cases, the stockpiles are beginning to exist, at least for the pre-hospital community. So some of them are starting to exist. So when all of a sudden there is a limited window, right, people are getting it. It's like seeing that pitch coming right down the middle. You don't get that very often, so swing. So as of today, Cardinal Pharmaceuticals, for example, has 10 milligrams in 2 mLs, which is the correct concentration of Versed, although not the standard volume that we normally carry, all right, has it available. Therefore, if folks were to buy some of it today, they'd be able to assure that they would be covered for tomorrow. So I sent that information to one hospital that I knew was getting short. From a state perspective, the Remac created a 3-physician advisory group to assist on the work with drug substitutions, keep an eye on drug shortages, come up with interesting therapeutic suggestions, and help guide us through the process of this drug shortage. I have no idea who those 3 physicians are. I understand there has been some email correspondence for those physicians, but it has not been shared with other members of the CMAC as of right now. Mr. Farrell, do you know anything about that? No. No, okay.
Michael, do you know if they also are looking at oral alternatives? One of the things that we have done in our region is we've pretty much stuck, other than things like Zofran, to parenteral methodologies. Maybe we're going to have to relax our criteria and then use some oral meds. Maybe is it optimal? No, but it's better than nothing.
That's a good point. And certainly ibuprofen instead of ketorolac makes a lot of sense.
And if you use liquid meds as compared to pills, they're going to get absorbed sooner than if you're using pills. And we have lots of, they're all workarounds. It's not the right answer, but there are ways of jury rigging this.
Some of them are. Some of them that probably we won't be able to have an answer for example, would be injectable benzodiazepines. We probably won't be able to come past that one. We're stuck with it. And back in January, we had a major crisis involving an entire 2 counties of our region. Actually, there were no injectable benzodiazepines available. That was one of the most profound crises that we've had. But we've gotten past that. So hopefully we'll continue to get past these one at a time. We may end up short of things at some point. Hopefully it'll be something that won't be too acute. Among the ones that are pending right now, etomidate is current. Magnesium is extremely short supply, but still available through compounding pharmacies, although at 5 to 10 times the cost that it previously was, which sounds an awful lot until we realize that that means it now costs $10 instead of $1, because magnesium was not particularly expensive. Etomidate is not available through compounding pharmacies, though. Bicarb is in extremely short supply right now. And no, you can't make your own with baking soda, although I have gotten that question.
I was actually going to suggest we have a card and start throwing some foxglove, and if that doesn't work, we'll have hemlock.
I think we'll actually have to bring Kevin back for that, as a matter of fact. All right. And no, we will not have therapeutic marijuana available on the ambulances. But I would like to point out that the state ban on synthetic marijuana was the subject of a conference call that I had during the academic meeting. And every conversation that I have had with physicians about this has been talking about the need for benzodiazepines and the care of patients who are taking synthetic marijuana. So maybe the commissioner's ban on synthetic marijuana will lead to a decreased need for injectable benzodiazepines, but I doubt it. Actually, if any of the physicians at the table have taken care of patients who've taken synthetic marijuana and these synthetic cannabinoids, please talk to me afterwards.
They need that.
Before I'm, what?
They need a lot of benzos.
They need a lot of benzos. Yes, they do.
Speaking of stockpile, I think you probably need one for July.
Yes. Yes. Different conversation. Very different conversation. Pyxis compliance issues. Art, you want to talk about that real quick?
No.
Okay.
No, it's still ongoing battle, at least at Albany Med, that we're working on. Whether we just met today again with, now it seems to be, we at Albany Med, we specifically have agency codes, no passwords. We're looking at PIN numbers that'll be EMT numbers, bio ID. But we keep on having a roller coaster ride of things are great and then things are awful. Continue to go out there and reconcile the Pyxis and the consortium from down the street. IV catheters are being placed back in, Albany Med stuff, expired stuff is put back in, and stuff is taken out. It's an ongoing battle.
And sadly, it's one of the things that's really important in making sure our system continues to work. So hopefully we can get some of that reconciled. The votes actually did take place last month, so thank you very much. Any new business from the floor?
The question was something, it's something we brought up in the past, and it might need to be refreshed as the process is being and figuring. To get on the CME calendar, what are the requirements that you need before you'll put them on the calendar?
Basically, we get the information of the CME and some sort of an outline of what's going to be taught. It could be just like 3 bulleted points, objectives, what's going to be taught.
And that outline does or does not have to come from the presenter?
No, it does not have to.
But where this is coming from, on more than one occasion, there are CMEs given right near each other. In one case, actually, it was on really the same subject. Mike and I were given it the same night at the same time. And we ended up combining locally because I happened to come into him in Lowe's, and he said, "This is stupid, let's combine it."
And it was a lot of fun.
And it was a lot of fun. But looking at the big picture, the problem still is ongoing. And I was just wondering if maybe we could, there's no way we can mandate that they work through us and mandate when people give or don't give their CMEs. But I think if we make an email plea maybe once a month for the next 3 months, we send an email saying, please check the CME calendar to see if anyone else has your particular date. And then once a year, we just send a reminder email saying before you make the CME that you look at the calendar and see if you're going to step on somebody. If it's at the other end of the region, then that's fine. But as I go through the CME calendar several times per month, you see the same sort of sector having 2 things at the same time. And I think in the long range, it really just does not make sense. I know we can't mandate it, but I think for people, if they get used to it and they keep getting reminded about it, it may be beneficial. Any other thoughts?
Any other agenda items?
I think I remember in 2003, you bringing up the same thing.
Yeah. It's been going on a long time.
Perhaps an agenda item for academic committee.
An excellent idea, Dr.
Put it
Allen.
on board list.
We should talk to the chair about that.
Yes, it's already been added.
Excellent. Sarah?
One other thing, with all of the stroke centers having to give EMS stroke lectures every year, I'm kind of curious as to whether providers are kind of getting sick of the same lecture. If there's anything new that we could present related to stroke that would qualify, that would count as our presentation to you for stroke, but would teach you guys something more than what you have been taught? Is it, because bottom line, I'm going to be giving a stroke talk next month.
Sarah, do you know if the regional consortium of stroke centers that does a whole bunch of education and actually put on a really nice dinner, and usually puts on a nice dinner every spring, I think, maybe it's every fall.
It's about this time.
Yeah. Do you know whether or not that counts for any of the stroke centers in their education?
Yes.
It does? Okay.
I'm going to say 2 years ago, a lot of the hospitals got together, I think in Rensselaer County. They went to one of the restaurants up there, and each hospital was represented by a physician or somebody, and they all gave a 15 or 20-minute little spiel on what their hospital had to offer and a little bit about the stroke stuff.
We've been doing that the last 3 years.
Yeah. If you find out what the hospital requirement is, share it with us,
Okay.
all right? Or actually, we just want to send Deb, Jewel a note and see, all right?
That one combined counts for all the stroke centers.
Mhm.
That's what they've been opting to do. The other stuff is gravy. They only have to do it once a year.
And the food was good.
Note for scheduling purposes, Dr. Vola's lecture topic may change.
Sadly, I don't think so.
Anything else?
No, just.
Old business item, and I missed last month's meeting, I apologize if it was covered. Back in January, lots of conversation regarding Boston Lake ambulances coverage scenario. Any update on that? at this point?
Boston Lake sent us clarification to their schedule, showing us that they were indeed covering their schedule the way they were supposed to. They're coming back to us in May with a formal report of how they're doing. And that meeting, that presentation was really supposed to be made was precluded by the state meetings that many of us attended.
Yes.
That's where that got. Any other business? All right, seeing none, what I'd like to do is move to executive session. Mr. Brandt, who's not here at all, can stay, that would be great.
You're welcome.